Hi, and welcome to the Summit at the Summit. I'm one of your moderators, Dr. Craig Wax, and to my right is Dr. Gina Melink. She is a hematologist oncologist from Hillsboro, Ohio, and you heard her speak yesterday to some very important issues with Ms. Twyla Brace of the Citizens Council for Health Freedom. So welcome.
Good morning, Craig. Thanks for having me up here with
you
all today.
We wanted to start with some of the beauty that is here at the Summit in Keystone, Colorado. The view from the workout room this morning, about 6 a.m., you're looking at now with the mountains in the background, and the sun hasn't completely come up yet, so the trees are still in shadow. Things are just gorgeous here, and it makes you think of nature, of freedom, of hiking, of cycling, of boating, and all the good, healthy things that we can do. We're going to take a look at a few more pictures from yesterday's dawn as well. This is a beautiful lakeside shot here, again with the sun just coming up, which began my bicycle tour of 20 miles yesterday morning before the conference from 6 to 8 a.m. before things got busy. You can see the path there. They have some glorious paths here for cycling, running, walking, hiking that go for miles and miles, literally tens of miles that go all around. And just the scenery was just gorgeous.
Absolutely.
I mean, the only thing that would make it any better or more regal per se would be like an American eagle flying into the shot by chance, you know, and then they'll take a picture and put it on a postage stamp, and that would be, you know, a designation of something. But this is, again, some more of the shots that go right through the trees, and you can see the all-important restroom sign. So there is signs of civility here, so that helps. A little bit of pavement also helps. These are some boats and things at the dock that we passed by yesterday morning, and you can see the bicycle sign with the down the hill. So make sure your brakes work really well, because you can't really downshift on a bicycle like you can with a car. This is one of my proudest shots with the reflection in the water of the sky and just the beautiful mountains in the background. Again, more roaring rapids if you're one to take the rapids in an inflatable or whatever your thought is. I wouldn't do it in a barrel per se, but I think it's just a beautiful, beautiful scene and a great, great place to visit.
We've had a wonderful time as well, Craig. We've taken advantage of some of that. And isn't it symbolic that we're here where the Continental Divide is?
Yes, absolutely, because we're sort of at the healthcare Continental Divide.
Absolutely.
That was a great lead-in. Thank you. And that was unplanned, just so you know. Having said all of that, we're here getting the panel discussion started before our first speaker at 8:30 Mountain Time, which is 10:30 Eastern Time, which is what my body is still on, and why I woke up at 3 o'clock this morning wondering why it was still dark. So got up and went to the gym and got active, made sure my slide set for this afternoon was ready, and off we went. Before I forget, because we're going to start talking about all the healthcare issues that the Summit at the Summit for LetMyDoctorPractice.org was organized about, we wanted to thank the sponsors, Merritt Hawkins, which is a doctor placement company, and PrimeEd, which a lot of physicians are familiar with as they provide low or no cost CME, and also makers of InLight EHR. Right. So that's our conflicts of interest potentially, so they're out there. That's very important. I know at the beginning of every radio show when I'm interviewing a guest, I always have them declare what their slant is, where they're from, where their bread is buttered, so to speak. And although I'm not a fan of bread or butter, it's the analogy that's the important thing.
Right.
So having said that, Dr. Melink, what do you think so far in the conference have been the high points for you as a physician and as a patient and as a mom?
Well, that's really true.
Big question. Several parts.
Right, three different hats right there. I think what I'm most struck by is the collaboration of groups coming together with similar concerns and empowerment. And to me, that's been the most strong part, and I hope that that continues as we work on.
Certainly, and that goes for the typical organized medicine, the bigger entities, and a lot of the smaller entities, which are doing a lot of the difficult legwork in trying to make sure that patients are heard and physicians are heard. In my belief, I believe medicine, like many things, even running a country, is bottom up. It's about individual people, not even groups, even more simple. The smallest group I can think of is an individual, because although perhaps I fit in a few groups, and maybe you do also, individually I'm different from those groups, and you're different from your group. So I think there needs to be some tolerance and understanding of individuals, and those people can come up with ideas, and instead of coming down the chain from the top, going up the chain from the bottom is hugely important, and I think that's what our country was designed to do in the readings I've done and my understanding of things. And potentially we've strayed from some of that due to big interests, but I think that the system itself ideologically is sound, and what can we do to rescue it? And I guess I'm sort of foreshadowing from my talk about restoring health freedom, the problem and solutions. I'm going to have the privilege of discussing 100 years in 30 slides in 30 minutes. So I'll try to use my best Northeastern dialect and move quickly. Forward. And
well, I think what's also important is that I think what I've realized also is our profession has become somewhat fragmented as we've become more subspecialized. And then with hospitalists, rarely we meet together anymore. And so we need each other. And I think that's what we're also recognizing, that together we can do something individually is a little more challenging.
Right. The days of the individual family physician and individual internal medicine doctor seeing patients for 12 hours and then rounding 9 to 12 at night, going home, pretending to sleep, and starting the process again. Hospitalists have risks and benefits. I'm sure we would all agree it's useful to have them there all day long, and certainly they can respond to things, but by the same token, they can't possibly know a new patient as we know a patient that we've seen for 20 years and 2 generations of their family. So it's, pluses and minuses. One way to bridge that gap for human contact as opposed to electronic contact, which I talked about, EHR is a great promise. However, with the expense and the execution of it, it's something that holds us back. It doesn't bring us forward, it holds us back. And that's indeed an issue. And with electronic continuity, other people may have access to ones and zeros and bits and bytes, but people are analog. We're people. And I find one way to bridge that gap, and maybe you found this in your practice, if like a family doctor, internal medicine doctor calls you and you're going to be in the hospital, I want to tell you about Mrs. Smith. She's a 38-year-old with this, that, and the other, and here's what my concern is. Let me know tomorrow what you decide to do. That makes all the difference. What's your thought on that communication process with an analog phone? Right,
it makes a huge difference. I think probably, unfortunately, as we've become a little bit less connected, I see less of that. And so it prompts me to pick up the phone and make that initiation, or people consult and the patient is sent without anything. They don't even know why they're there, and when they hear maybe it's an anemia, but they see I do oncology, excuse me, that's very frightening.
Sure, absolutely. Case in point, yesterday when we were doing presentations and I was fortunate enough to be asked to be moderator in between, kind of the bridge between important topics, I got a call, despite me having another colleague on call, I got a call on my cell phone from a major city hospital ER about a patient. And I said, for pragmatism purposes, I'm in another state, another time zone, yada, yada. It's hard for me to respond, although I know the patient, to some degree. And I gave them the information of the other physician that could be there to respond more acutely. And she said, the patient wanted me to call you. The patient and their family wanted you notified wherever you are and to approve of whatever the treatment path is going to be. So I spent a few minutes talking to the ER doctor about the way they presented and what a rational approach would be. And I said, you know what? Tell the family you talked to me. And we agreed on the course of care, who was going to administer it, what tests would be done, and what treatments would be done. And that way the patient could rest easier, knowing that their doctor for a decade or better had some input and some influence.
Right. Absolutely wonderful. Yeah. And
I've spent, gosh, close to 2 decades anyway, speaking with emergency departments, and as they get bigger and more busy and more beds and higher turnover and longer wait times, trying to be drive-throughs with shorter wait times, they don't often call. And I talk to the ER physicians who are my colleagues, and I say to them, look, I can help you make your job easier. If you call me, I can let you know everything that I know in a brief 60-second time frame, and then you can let me know what you know, and the patient can have the benefit of all of that. You can call me at any hour, any time, with regard to that. And so many times, ER physicians don't do that, and 2 days later, you get a 10-page summary of their 6-hour ER stint that may or may not be accurate, but it's certainly an issue.
As well as medicationless. I mean, that's a major problem. And I think the real issue is they used to call a little bit more, I think, but EHR has not replaced that personal touch or communication.
I think that's a point that makes worthwhile bearing again and again, that you can't replace personal human connectivity with electronic connectivity. You just can't. It's a nice supplement potentially, but it's certainly no replacement for the human contact factor.
Absolutely.
Because there are things that you know about your patient and their family and current stressors that aren't in the medical record.
Absolutely.
And what if somebody comes to your office and they bring like a USB drive or an SD card and they said, doctor, here's 20 years of my data, okay? You're now responsible for that. And you go, how am I possibly going to be responsible for all of those electrons? And even worse and more simply, am I going to plug that into my computer immediately, assuming I could read it and the format was similar, and I had 1 million hours to do it? What if it gave my computer a virus? I can't plug that into my computer, because my computer, if it has a virus or a problem on the internet, I'm in trouble and the government's after me. Because the government, although they promise security and privacy, they can only penalize people who don't do it. And that's, unfortunately, a bad model, because they've promised everybody, we're going to make this happen. But they're not making it happen. They're just penalizing if it doesn't happen, which seems to be what does happen. So what is your advice to someone who's accessing the healthcare system or seeing you for the first time? What should a patient do, bring to your office maybe, and what helps you to communicate and to know in 30 minutes what you need to know?
I think what's most important is they understand from their referring from their private doctor, their family doctor, their internist, or their pulmonologist, why they're being sent. And if they have a clear understanding of that, we have a baseline from which to begin our discussion, whether it's a blood-related or it's a cancer-related problem. I think that's most important. Obviously, getting reports of x-rays and labs is very helpful, but where the patient comes from, their understanding is absolutely key. Because I spend a lot of time going back first to assure them, here's why you're here, and we're going to go through it, and it's going to be okay.
Well, you have to form your understanding from the situation, and also it would be helpful if the patient shares their understanding so you know where they are and what they're thinking, and perhaps the primary care physician's understanding, because he or she may have a different perspective on the forest and the trees.
Right. And their understanding and appreciation for their years of knowledge of that person, where they are. How the patient often presents themselves is sometimes a little bit different emotionally because I'm a new person to them. So it's very valuable to know years of relationship, how that...
And speaking of relationships, that's another important thing. When you see your family doctor or your internal medicine physician or whoever's serving as your primary care coordinating person and primary advisor on things, it's important to also find out what specialists they know and trust. because I've got 2 decades worth of experience of specialists that this one I would call in a heartbeat for this problem. This one, no, not so fast.
Sure.
Depends. And some people say, I want a male doctor, I want a female doctor, I want an older one, I want a younger one, I want to go to the big city because it's better, and I want someone who's local so I can see them and they can help me and my family.
Right.
There's so many different things in choosing a physician, whether it's primary care or one of the specialties.
Right.
And that's also important because patients trust us to ask questions because there's cost, there's accessibility, potentially there's insurance issues, possibly government issues, there are preference issues, and many, many issues that go into who do you refer to.
Right.
It makes a ton of difference.
I think from my standpoint, practicing rural oncology in particular, some people worry. Are they getting standard of care that they could get perhaps closest to us as the James Cancer Center? So I take that opportunity to even initiate it so they know it's all out on the table. I do share with them that I usually can get everything they need, biopsies, x-rays, staging, whatever, and then get them up there so that everything, and they're not wasting time back and forth. And assure them I'm happy to include a larger team. And,
right.
and people appreciate that when you initiate. It does not intimidate me at all.
And
I welcome it.
I have found, too, that if I want to refer a patient to a certain place and they have their heart set on being elsewhere, unless I know that that's harmful or dangerous, I'll go along with what the patient wants. Because
Sure.
if I send them to the greatest place in the world and they're dead set not to like it, you can't make somebody
Absolutely.
like it. You can lead a horse to water and educate them on the water, tell them how to take the water, the side effects and issues with the water, the package insert from the water, and they may exercise their unique individual right to not take the water. And that's fine. That's definitely fine. But the one thing that I wanted to share also, which you may feel the same thing, and this not only goes for healthcare, but it goes for every other aspect of your life. When you're talking to someone about making any kind of bargain, whether it's healthcare or you're buying a car, it could be anything common practice, you have to think in terms of what's my cost going to be, what's the access going to be, what's it going to do for me, how many miles per gallon. You got to think of all of those things, and they're very personal to every person's own moral and ethical judgment system that may be different from our own, and we have to be respectful of that.
Right.
You know, maybe we have one perspective and they have another perspective. The one question that I can share, and this is a take-home point from this section, would be if you're ever in a doctor's office and you're confronted with more options than you know what to do with, and you just don't know, and you're overwhelmed, and there's either family there or not there, and you're just confused, the simplest question that cuts across everything in whatever it is, doctor, what would you do? Precisely. Precisely. I mean, it does apply our own value system, but it does take into account all of those questions. So if you're ever at a doctor's office or anywhere and you have a question, you can always say, doctor, this is rather overwhelming. I'd like to go home and think about it, but what would you do if you were this, or I was your daughter, if I was your son, if I was your mother, if I was your father? And that makes it simple, because we doctors have experience and what they call opinions. You know, we've all got them, and some of us have more than one, actually. Patients have their own as well. And what would you do cuts across all of the questions. So it's not where to hang your hat 100% of the time. Certainly, we're not asking for blind indulgence. However, it does help if you're confused and there's just too many things to possibly consider.
Right.
Would you agree?
I would agree with that. I would agree. And I found personally, my mother's 88 and has a large 1.1 centimeter ureter stone.
Wow.
That
Ouch.
needs to come out. She's been septic twice. So the first urologist stood at the door and said, I'll see you when you're discharged. Well, he's an excellent. But it was just that turned her off.
There was no personal contact with the patient. There was no what's important to you. Is there any unmet needs that we can take care of? Is your pain medicine being addressed adequately? That's number one, that hydration.
And, and he realized she was septic and couldn't, and I understood, but she did not. And so we've gone elsewhere and to other people, as a matter of fact. So patient care to people is oftentimes touch. It's show that you care on a personal level. It's not about just the disease. It's about the person with that disease. So it's been a very interesting.
Yeah, well, it's very hard to do, too, assuming you're the patient and I'm the physician. And I'm saying, so, madam, what brings you here today? Do you smoke? Do you drink? Do you do drugs? What's your sexual history like? And wait a second. I mean, all of that's good information and to be taken in context, but my back was to the patient. I wasn't addressing the patient. I was addressing the big square screen, and I was addressing potentially all of the issues of EHR, what the government's need for what they call meaningful uses, what the insurance companies' needs were, but whose needs was I not addressing? The person that's here in front of me. And that's why restoring the patient-physician relationship with a direct relationship, where potentially the patient pays the physician a reasonable fee, and insurance companies, they can bill their insurance. I'm happy to give them all kinds of receipts and whatever they need to do. But if I have to dance for the insurance company and for the government and the medical legal team, I can't dance for the patient. So I'm probably not going to be what the patient wants. Just like that urologist that you mentioned, which may be the best one on your schedule, but he didn't address the patient and her concerns.
Right. Absolutely. I agree with you.
So what else do you find in the last 3 minutes of our time is important to address of a patient's concerns? Bringing the fragmentation back together in the patient-physician relationship.
I think communication is key, absolutely key. I think that's number one. With colleagues, with patients, with families, I think that's absolutely key. And then we are also responsible to make sure we are up on all of our own education. We need to understand how science is changing, how medicine is changing, and be responsible advocates, and we need to support each other.
That's important, and that's another important thing to mention about the conference here today, letmydoctorpractice.org. Thank you again for being here. Those of you that are here in person, thank you for those who are joining us on the internet, whether you're joining us live or you're joining us at a later date. All of the issues that we're dealing with are the current issues, and the speakers have been excellent, from the congressmen to the physicians to the authors to the physician software technologists that we've met, and everybody shared a quite similar perspective with regard to getting the human part back, because the human part is being lost, and it's being lost by inches, so you barely recognize it. It's like the boiling frog analogy. You know, if you throw a frog into boiling water, sorry about the starkness of this, if you throw a frog into boiling water, he jumps out. He jumps out, saves his life. However, if you put a frog in warm water and you turn it up a few degrees an hour, he'll die. He will die.
Sure.
He gets used to it to the point where he doesn't respond anymore to the stress.
Right.
So, you know, certainly we don't want the patients to be that person, but as physicians nowadays, we're feeling like that boiling frog, and we're sensing that our temperature is exceeding what we're able to do and still do our job.
Right.
And it's difficult to jump out.
Right.
Because we've always been in the boiling water. Always. And I always tell patients, Your problems are never a problem. The insurance company, the government, the medical legal system, everybody that doesn't belong in this exam room that tries to get in here, they're the problem. I always tell patients, bring me anything you want, we'll address it. We'll do it reasonably, we'll do it straightforward, we'll do it when you need it, and if there's a solution, we'll help you find it. And sometimes it's a long course, but if you're honest with patients from the word go,
Important.
it's usually important. Well, thank you, Dr. Melink, for being with me this morning for our panel discussion on communication and the patient-physician and even the physician-physician relationship.
Thank you, Craig. You've just been a wonderful asset to this program. I have to tell you, thank you for everything you've given.
I'll give you one of these. There you go. My kids taught me to do that, and I thought, you know what, that's a great thing. That's a great thing, not to potentially spread disease, and yet you still get to make human contact.
That's right.
Eye contact, hand contact. It's a winner from my perspective. Thank you again.
Thank you.
My pleasure.